Thank you very much. Actually, this was my PG who did the study with me has gone to England to pursue his career. So that's why I'm presenting on his behalf. This topic, we took the COVID. When COVID came in, the gold standard test was RT-PCR. And this was considered to be the more specific and sensitive test available. But it has not been freely available at many places, or sometimes if you ask for a PCR, the results used to come 24 to 48 or even 72 hours after the patient was admitted. So we were basically seeing patients coming to us with variable X-ray changes and then HRCT changes. So, and WHO also gave particular patterns which have been somewhat characteristic or specific for COVID in the pandemic time. So we did study, and we tried to look for this tool so as to identify the severely diagnosed patients, severely affected patients, and to treat them rightly rather than to wait for the PCR to come and then to start the management. So the aim, so if I just go through the background, that WHO has given some typical lung involvement patterns on HRCT, and there have been a COVID-19 reporting and data system, which was abbreviated as CORADS, and then there was a score which they used to do, which was CT chest severity score, and that has been a validated tool as a marker of lung involvement in patients with SARS-CoV-2. So this score may help to identify the patient with clinically severe disease who need early intervention. So if you go through this slide, so this is a patient with COVID-19. You can see the 4 or 5 changes which are typical of COVID. Number 1, bilateral involvement. Number 2, ground glass opacification, mostly on the posterior distribution, and multilobar, and it is peripheral. So majority of these changes we were seeing in the COVID area, and in a particular patient who is coming to us with the signs and symptoms in the pandemic, if we see this HRCT, we were quite confident that this is a COVID, and we used to, when we can start, but anyway, the gold standard has been RT-PCR. So we aim to identify if there is any correlation between the clinically severe parameters. So the clinical severity, the CT severity has been devised, and that's a tool available. So we wanted to compare whether it goes with the clinical severity or not, because sometimes we had patients with minimal involvement of the lungs, and they have clinically severe disease, and we did find some patients otherwise. So there were 2 aims. Number 1, to identify a tool to quickly identify the patients, and number 2, whether we can we have a tool which correlates well with the clinical severity or not. So this study was conducted at KRL Hospital Islamabad, and it included the patient with COVID-19 admitted into the dedicated COVID-19 ward or an ICU, and this was conducted from November 2020 till June 2021. Patients were categorized using the WHO-defined criteria for the clinical severity as non-severe, severe, and critical. So the criteria has been devised earlier in the talks as well. So anyone with signs and symptoms with no hypoxia, and the other patients with signs and symptoms with hypoxia, they come in the severe category, and if they had ARDS, sepsis, or septic shock, they had the critical disease. This is the criteria given by the WHO. The radiological severity was measured during the CT-SS score, in which what they do is there is a sum of the score. 20 lung regions are studied by the radiologist, and they score from 0 to 2. 0, no involvement; 1, less than half of the segment involvement; and 2, if the whole segment is involved. So this score is ranging from 0 to 40, and the radiologists, they used to read the scan and gave us the score, and The cutoff was 19.5. So if the person has scored more than 19.5, they had a CT severity of severe disease radiologically, and less than this was a milder disease. So all the CT scans which were done, they were reported by the classified radiologists of our hospitals. So we recorded all the signs, symptoms, and demographic data, and the comorbid conditions available. These were the labs which we organized as per the hospital protocol during the COVID season, which included the blood counts, LFTs, RFTs, coagulation profile, CRP, LDH, D-dimer, and ferritin. Some of these parameters were used to look for the severity of the disease. The patients who were referred to us, if they are admitted, they were followed till discharge or death. And the non-admitted patients were followed in outpatient basis with a weekly clinical assessment for 2 weeks or until recovery, or if the PCR has been negative as per the hospital policy at that time. We did the chi-square test to determine the association between the categorically variables, and the significance was set at p level of less than 0.05. The independent t-test was used for the CT scoring, and we utilized the one-way ANOVA test to determine the difference among the means of the clinical severity and the CT severity. So in total, during that time, we had 205 patients. They were recruited. The mean age was 57, and 57% were male, so 43% were female. 62.4% they required hospitalization, and out of them, 22.9% died. The most common symptoms were fever, followed by cough and shortness of breath. So these were the three main symptoms which these people have. And the medium duration symptoms before coming to us was 6 days. This table shows you the people who have the CT severity scores. So 57% of the patients had CT severity score of less than 19.5, and 43% have CT severity score of 43. And on the other side, it's the clinical severity. 48% of the patients have non-severe disease, and 52% of the patients have severe or critical disease. We looked at the mortality in both these groups. So it clearly shows the mortality rises as the CT severity or the clinical severity rises. So the independent t-test was run to see the correlation between the disease severity and the CT severity score. Now, if you see this table, here we see the non-severe critical. So we see that the CT severity increases as the disease severity is increasing. So that basically, this was a correlation which we were eager to find out whether we can rely on the CT severity to stratify these patients. So it did show that there is a positive correlation. So people who have severe disease on CT, they are going in with the severe disease. This is further extrapolation with the Tukey's test, and it showed a significant difference in the CT severity among all the groups. So in conclusion, a higher CT severity score was related to a higher clinical severity, and which was associated with a poor outcome, because quite a high mortality in the people who have a severe disease in both cases. And now it is vital that we should identify these high-risk patients so as to start the treatment quickly and to save the lives. Thank you very much.
Thank you, sir. This brings us to the end of the presentations. Any questions are welcome.